Good morning. Thank you for joining me once again for the pharmacology class. So last day I had stopped till melphalan, which is belonging to the nitrogen mustard group, and here we had completed the nitrogen mustard group, which is one category under alkylating agent. Alright, so we will continue from here with the remaining categories under alkylating agent. The second group under alkylating agent, under cytotoxic drug, and under the alkylating agent we have is thiotepa. Thiotepa, it belongs to the category ethylenamine, and it does not require to form any active intermediate. This drug, due to its high toxicity, it's rarely or it is seldomly used nowadays. Okay, so in short, if I say we don't use thiotepa drug nowadays because of the high toxicity rates. Okay, so this is about thiotepa. It belongs to the group ethylenamine. So remember, it does not require any active intermediate. It has got a very high toxicity. As a result, we don't use it. When it was in use, the dose was 0.3 to 0.4 mg per kg intravenously, and it was given at 1 to 4 weeks interval. The third category under alkylating agents we have is alkyl sulfonate, and under alkyl sulfonate we have the drug busulfan. Now busulfan, it has got a very good specific, or it is highly specific towards the myeloid elements. Okay, the myeloid elements, it has got much affinity, and its precursors, or the granulocyte precursors, being very sensitive towards it, followed by platelets and RBCs. So it is very specific or highly specific towards myeloid elements, and granulocyte precursors are very much sensitive to it, followed by the platelets and the RBCs. And if you take the lymphoid tissue, it produces only very little effect, and as well as on the GIT tract. So lymphoid tissue and GIT tract, very little effect. Hyperuricemia is very, very high here, along with that pulmonary fibrosis. Okay, along with pulmonary fibrosis, which is a specific adverse effect here. Sterility can also occur, and it is still considered as the best drug of choice for chronic myeloid leukemia. This will be considered as the drug of choice. Okay, and the dose is 2 to 6 mg per day, or we will be administering at a dose of 0.06 mg per kg per day orally. Mg per kg orally we will be administering this. So once again, busulfan, it belongs to the group alkyl sulfonate. It has got a very high affinity towards the myeloid tissue. The granulocyte precursors are very much sensitive, followed by the platelets and RBCs. A very little effect upon the lymphoid tissue and GIT. Hyperuricemia as well as the pulmonary fibrosis is very common, and pulmonary fibrosis is a specific toxicity you can find, or as an adverse effect you can find here. Sterility can also occur, but still, despite all these, still it is being considered as a drug of choice for chronic myeloid leukemia. And the dose it will be administered is 2 to 6 mg per day, or 0.06 mg per kg per day orally. Moving on to the next category called as the nitrosurias. Nitrosurias, we have two drugs, lomustine and carmustine, and these are highly lipid soluble drugs, alkylating agents, lipid soluble alkylating agents, and they possess anti-tumor properties. They have an advantage of crossing over blood-brain barrier. Okay, they have a very good advantage of crossing over blood-brain barrier. Hence, it's very useful in treating meningeal leukemias or brain tumors. And nausea, vomiting, they are very common. CNS effects can also be noticed. Bone marrow depression is peculiarly delayed. It takes about 6 weeks for it to get developed. But visceral fibrosis, renal damage is very common, or it can happen over here. And if we go for administering, the lomustine will be given at a dosage of 100 to 300 mg per meter square body surface area, oral dose for about 6 weeks. Okay, every 6 weeks we go for administering. So this is about nitrosurias. Nitrosurias, we have two drugs, carmustine and lomustine. They are highly lipid soluble alkylating agents. They have a very good anti-tumor properties. They have an advantage of crossing over the blood-brain barrier. As a result, we can use it for treating brain tumors, meningeal leukemias, okay, and nausea, vomiting, they are very common. CNS effects can also be noticed. Bone marrow depression takes 6 weeks to occur. But visceral damage, visceral fibrosis as well as the renal damage can occur. So make it a point of monitoring or generally examining your patient and also keeping intake output chart recorded. So lomustine, it will be given at a dosage of 100 to 300 mg per meter square body surface area as a single oral dose every 6 weeks. And in the form of capsules, we have 40 mg and 100 mg capsules available. And moving over to the last group of cytotoxic drugs under the alkylating agent is triazine group, and under that we have dacarbazine. So if you see, it's quite different from the other alkylating agents. This is going to really act upon the RNA strand and the protein synthesis, not the DNA. All this while we had seen these alkylating agents were acting upon the DNA strand, but here it's going to interfere with the RNA strand. And once it enters into the body, it gets activated in the liver, and important indication is malignant melanoma as well as in case of Hodgkin's disease too. The prominent side effects are only nausea and vomiting, and a dose of 3.5 mg per kg per day intravenously for 10 days and repeat after 4 weeks gap. So this is about the alkylating agents we had seen under cytotoxic drug. Okay, so once again I'll talk about alkylating agents. So alkylating agents, they are very highly reactive carbonium ions which will be produced so that they would be able to transfer the alkyl groups to the cellular macromolecules by forming a covalent bond. So once the alkylation takes place, they are able to result in abnormal base pairing or cross-linking or even scission of the DNA strand. And if you see, there are certain advantages. We have cytotoxic, it is radiomimetic, and it is cell cycle non-specific. That means it's going to act even upon the resting cells too. Apart from that, it is CNS stimulant, and also it possesses certain anticholinergic properties. So the first drug we had seen under nitrogen mustard was mechlorethamine, otherwise called as the mustard hydrochloride. So it is the first nitrogen mustard drug which was discovered. It is highly reactive and it is a local vesicant. It has to be given intravenously. Since it is being given intravenously, remember, it can cause extravasation resulting in sloughing, and apart from that, nausea, vomiting is very common here, along with hemodynamic changes. So the dose that we will be giving is 0.1 mg per kg intravenously daily for 4 days, and courses can be repeated at suitable intervals. The second drug we had seen was cyclophosphamide, okay, and it is inactive when you see or when you compare it with the mechlorethamine, and it produces only very few acute effects, and it is not locally damaging, and it gets transformed into active metabolites once it enters into the liver. Possesses a very good variety of anti-tumor properties. It is a very good immunosuppressant, and also it is causes less damage to the platelets, but you can find alopecia and cystitis, which will be prominent because of the metabolite acrolein, which will be formed. And if you are giving chloramphenicol with this particular drug, it is going to retard, or it's going to reduce the metabolism of cyclophosphamide. Okay, so we need to be careful in that area. And the dose is 2 to 3 mg per kg per day orally, or 10 to 15 mg per kg intravenously every 7 to 10 days, and even intramuscular route is also possible. Coming over to ifosfamide, it is a congener of cyclophosphamide, but it has got a longer dose dependent as well as longer half-life, and it has got various uses like for bronchogenic, testicular, ovarian, bladder, and even head and neck carcinomas, osteogenic sarcoma, as well as in some lymphomas. But the only dose limiting toxicity is hemorrhagic cystitis, for which we will have to go for administering drug mesna, okay, because it will prevent the metabolite formation. It will inactivate that metabolites. Though this gets converted to active metabolites in the liver, the particular metabolites, once it is formed, it will get inactivated, so it will not be able to produce much side effects in it. But it causes less alopecia and it is less emetogenic when compared to cyclophosphamide. Chlorambucil was the next drug that we had seen. So compared to all these drugs, this is slow acting. Chlorambucil is slow acting and it is very active on the lymphoid tissue. Myeloid tissue is spared. Okay, myeloid tissue is spared here. That means it's not going to act. It's going to avoid that tissue. And it's a drug of choice for maintenance therapy. Maintenance therapy for chronic lymphatic leukemias, Hodgkin disease, and some solid tumors can also resolve. And also it has a very good immunosuppressant property too. The dose that we will be administering is 4 to 10 mg or 0.1 to 0.2 mg per kg daily for 3 to 6 weeks, and then 2 mg daily as a maintenance dose. And the last one under the alkylating agent was melphalan. Melphalan, it's very effective in multiple myeloma, and it is being used in advanced ovarian cancers. Bone marrow depression is very important toxicity you can find here. As a result, patients start developing infection, diarrhea, and pancreatitis. The dose that we will be administering here is 10 mg daily for 7 days or 6 mg per day for 2 to 3 weeks. And after 4 weeks gap, we will be administering 2 to 4 mg daily as a maintenance dose orally. Then today's drugs that we had discussed was thiotepa. Thiotepa belongs to ethylenamine and it does not require any active intermediate, but due to its high toxicity, it's seldom used. Dose is 0.3 to 0.4 mg per kg intravenously for 1 to 4 weeks interval. Moving over to alkyl sulfonate, we had seen the drug busulfan. Busulfan, it has got a very high affinity towards the myeloid tissue, and the granulocyte precursors are very sensitive, followed by the platelets and RBCs, and a very little effect will be produced upon the lymphoid tissue and GI tract or gastrointestinal tract. Hyperuricemia is common, and you can find pulmonary fibrosis as an adverse effect. Sterility can also happen, but it's a very good drug of choice for chronic myeloid leukemia. And the dose that we administer is 2 to 6 mg per day or 0.06 mg per kg per day orally. Coming over to nitrosurias, we had seen two drugs, lomustine and carmustine. So this is highly lipid soluble alkylating agents. It has a very good anti-tumor properties. It has the advantage of crossing over the blood-brain barrier. Hence, it is used in meningeal leukemias as well as brain tumors. And nausea, vomiting is common. CNS effects can also be noticed. And mode marrow depression is peculiarly delayed as it takes 6 weeks to be developed. But visceral fibrosis and renal damage can happen. And lomustine, if you're taking it, is 100 to 300 mg per meter square body surface area, single dose orally every 6 weeks. And coming over to the last group, that is your triazine group under alkylating agent, we had seen about dacarbazine drug. It's very different when compared to all the other alkylating agent because this is going to act upon RNA strand. Okay, it's going to act upon the RNA and the protein synthesis, and it gets activated in the liver, so it is a very good drug of choice in Hodgkin's disease and as well as in malignant melanoma. And prominent side effects are nausea and vomiting. The dose that we administer is 3.5 mg per kg per day intravenously for 10 days. And we will be repeating it after 4 weeks. So with this, I have completed alkylating agents. In the next class, I'll be starting with antimetabolites under cytotoxic drugs. Thank you.